So welcome back to Pharmacology with Dr. Sokolow, and this is the last module on anti-infectious agent and specifically on antiviral agent that are used for the treatment of HIV infection. So what is HIV virus? So it's a retrovirus and has only one single strand of RNA. It must be first transcribed from the RNA into the DNA in order to replicate. And the viral enzyme allowing this step is called the reverse transcriptase. So HIV virus infection is a chronic infection, and to treat HIV, because of the resistance to the numerous anti-HIV medication, patient who has HIV need to be on several antiviral medication in order to keep their viral load to a minimum. So this is the HIV production, so the HIV reproduction cycle. So you see here you have your HIV particle that bind to the CCR5 receptor of a CD4 cells, and then it's gonna fuse with the membrane of the cells and then release its single strand RNA, which then will be transcribe into a single strand DNA, and then replicates within the cells, and then we're going to integrate into the nucleus of the infected cells, and that's where you're going to have the transcription of this double strand DNA of those virus, HIV virus. You see, you're going to use the machinery of the cells to be transcribed and translated into those viral protein, and then they're going to assemble into a new virus particle, get bud off, and then can spread and infect the neighboring cells. So you see different enzymes are involved in this virus replication, virus production. So you have here, you can inhibit, and so if you can interfere with any of these steps, then those agents will reduce, the viral load of the HIV viral load and reduce the infection. So first, you have drug that can block the fusion of the virus with the host cells. You have the CCR5 inhibitor will block the attachment of the virus to the surface of the cells. Then you have the NNRTI and the RNRTI that block the reverse transcriptase. Then you have the integrase strand transfer inhibitor. So this will block the integration of the viral genetic material into the nucleus of the host cell. And then you have the protease inhibitor, which is the last steps in this replication cycle. And so we're going to talk about the different agents. So HIV drug, it's called, the therapy is called the HARD therapy, for highly active antiretroviral therapy. And this is the standard treatment. You see, it requires 3 to 4 drug regimen. There is no, not a single drug that will be effective in treating HIV infection, and by given those 3 to 4 drug regimen, you can decrease the plasma HIV to undetectable level and delay the loss of immune function. Of course, they're expensive, complex, lot of drug interaction. They must be lifelong, and of course, you're going to see the main problem is the adherence to the treatment with those multi-drug regimens that are so complex and give so many adverse effects. So first, let's talk about the reverse transcriptase inhibitors, and there are 2 different types. You have the nucleotide. So nucleoside and nucleotide are the backbone of either your RNA or your DNA structure. And if you block the reverse transcriptase, you block the incorporation of those nucleoside or nucleotide into either the RNA strain or the DNA strain. So they are similar structure to the naturally occurring nucleoside or nucleotide. They act as a substrate for the reverse transcriptase, and so therefore they inhibit the synthesis. So this sign means synthesis of the viral DNA by preventing the reverse transcriptase to add more base into, either the mRNA or into the DNA structure. So the prototype is zidovudin. That was the first drug used for HIV therapy, and since then, there are like other one that became available and are more effective when used in combination. You have anthracitabine and tenofovir, and you also have lamivudine. So these are the nucleotide RTIs, so reverse transcriptor inhibitor. They are called the NRTIs. Now you have the non-nucleoside RTI, so NNRTI, because their structures are not related to the naturally occurring nucleoside. So, but they still inhibit the HIV reverse transcriptase, and so inhibit, the synthesis of RNA or DNA virus. So here they are non-nucleosides, and this is one of the most commonly used is efavirenz. Again, this is not used in single therapy and monotherapy, but they are used in combo therapy. They are used with other agents. Now you have the protease inhibitors, so ritonavir. So you inhibit the HIV protease and prevent the maturation of HIV. So you remember it was the last step. So ritonavir, atazanavir, and prenavir, they have all the same ending, and those protease inhibitor has a long, they are known as CYP3/4 inhibitors, a long list of drug interaction. Now you have the integrase strand transfer inhibitors, so they prevent like the integration of the viral genetic material into the nucleus of the cell, of the host cell, so inhibit HIV-1 integrase, prevent viral DNA integration into the human nucleus and DNA. And this is because it's integrase, so you have grave, raltegravir, alvitegravir. And this one is in that combo drug known as Strobil. Now you have the HIV fusion inhibitor, so prevent the HIV fusion with the lymphocyte cell membrane. So one of the first steps in the HIV replication into the host cell, so block the HIV entry, and therefore, the steps ahead of the replication. This one is enfervirtide, so you see FU for fusion. And then the last one that was approved is a CCR5 antagonist, not an agonist. I have to change that. CCR5 antagonist, Maraviroc. So this one binds to the CCR5 receptors, and so also block the viral entry and all the steps that are, ahead of the viral entry and the viral replication. Adverse effects. So let's talk about the NRTIs. So the nucleoside reverse transcriptor inhibitors, black box warning, they can cause lactic acidosis and severe hepatomegaly. They can also cause rash and pruritus. Now you have the NNRTI, so the non-nucleosides reverse transcriptor inhibitors. Those can cause severe rash, like Stevens-Johnson syndrome. Then they also cause hepatic failure. They can cause psychiatric adverse effect like depression, psychotic disorder, suicide thought. And for efavirenz, it's teratogen, and so this one has to be avoided during pregnancy. The protease inhibitor, ritonavir, as I said, this is a CYP3/4 inhibitor, so there are many, not only there are many adverse effects, but also many drug interaction. So in terms of adverse effect, cardiovascular, it can cause AV block and prolong the PR interval. They can cause endocrine metabolic adverse effects such as hyperglycemia, hypercholesterolemia. Also can cause pancreatitis, hepatitis, and then they can cause immune hypersensitivity reaction and Stevens-Johnson syndrome. There is a black box warning when they are co-administered with hypnotic, antiarrhythmic, or echo derivative, where there is a potentially life-threatening adverse effect due to the CYP enzyme inhibition. So this is totally contraindicated with those type of medication. And now in terms of the regimen, as I said, it's complicated, but it's worth it because it's working and can really keep the viral load to a minimum. And so if you want to look at the guideline, I added this link. And so it's a trioquadride therapy, so monotherapy is no longer effective. The preferred regimen has at least 3 drugs from at least 2 different classes of drug. And this is to reduce the drug resistance and also to spare other classes for future use. So you want to start with the minimum number of effective drug, and if it's working, that's fine. But remember, this is a long-term therapy, and so as you know, the time goes by, and you can see the occurrence of resistance to one class of drug, and so then you would add another class as you know the patient is on hard therapy. But the initial recommended regimen for treatment naive, so patient who hasn't been, you know, on any HIV treatment before, it's to use 2 NRTI, so nucleoside or nucleotide reverse transcriptase inhibitor, and the most common one are abacavir, lamivudine, or tenofovir, alafenamide, and anthracycline, plus a drug from one of the 3 other classes, such as an integrase inhibitor or a non-nucleoside reverse transcriptor inhibitase. And then you can boost it with a protease inhibitor. So the PI by itself don't have, you know, any efficacy, but when you add it on, then you can boost the effect. And so you see the treatment, they are either called the NNRTI based regimen, where you have 1 NNRTI plus 2 NRTI, or you have the entity-based regimen where you have an entity with 2 NRTIs, and then you can have a boost with it's a PI plus 2 NRTIs. So these are the recommendations. So take-home messages: just monotherapy doesn't work for HIV patients. And thank you for watching this module on antiviral agent, and I will see you in class.